Okay, students, we're going to go ahead and move on now to our next chapter, which will be on psychological disorders or abnormal psychology. A lot of Gen Psych students think this is what general psychology is all about, and by this point, I'm sure you've come to realize that it is so much more. But this is often the area that has a lot of interest for students. So let's go ahead and talk about our learning objectives. These are the things that you need to be successful at and the things that you need to know in order to be prepared for the assessment. One of the things we're going to be talking about in this chapter is defining abnormal. What does it mean to be abnormal? And defining psychological disorders. We are going to be spending some time talking about the DSM. You need to be able to list the symptoms of anxiety disorders and understand what anxiety disorders are. You need to be able to list the symptoms of mood disorders and understand various mood disorders. We are going to be talking about the symptoms of schizophrenia. We are going to be talking about somatoform disorders, personality disorders, and also personality disorders. And then at the very end, we're going to talk a little bit about some of the social and legal implications of what it means to be diagnosed as mentally ill. All right, I want you to go ahead and take a look at this graph here. Though often we believe that mental health issues are unusual, in fact, it's actually quite common for people to struggle at various points in their lives with a mental health issue. This graphic represents the annual incidence of specific psychological disorders, and what it is it's several large-scale surveys that have been combined, surveys that have been done of adults in the United States, and it teases that data apart by specific psychological disorder. So you can see which one people seem to be typically struggling with. One of the things that I want to point out here is that in the United States, this data has revealed to us that nearly 30% of people experience some form of mental disorder in any given year, and that almost 50% of them have displayed a disorder at some time in their life. When we look at data or information from the World Health Organization, we find that the same general pattern appears among more than 400 million people worldwide. So this has a lot of implications for us when we start to consider, well, what does it mean to be abnormal? How do we define abnormal? Or what criteria are we going to use to consider a person's behavior to be abnormal? And in the past, we often considered this idea of deviance. When we consider a behavior to be deviant, what that means is that it's statistically infrequent. The behavior is unusual or it's rare. It's not something that we typically see. But this criteria, it's not a good way for us to be able to define abnormal, because what the data shows us or seems to indicate is that it isn't statistically infrequent. In fact, we could consider it somewhat common. So other criteria that we seem to look at are things like distress and dysfunction. Does the person suffer from their mental health issue? Are they suffering? And do they have impaired functioning? Do they have a difficult time dealing with their day-to-day lives and the tasks that they have to accomplish? Again, I want to stress this. About 30% of the adult population has had a mental disorder in the past year. And when we look at the population, about 48%, nearly 50%, have struggled with a mental health issue in their lives. So when we think about abnormal, or we try to define what it means to be abnormal, we try to take a very practical approach. What is the content of the behavior? What is the person doing? What is the sociocultural context of the behavior? Some behaviors, such as bowing every time you see someone, that's very normal. or typical in a country like Japan. Here we would not consider that to be normal. So we try to take sociocultural context into consideration. What are the consequences of the behavior? Does it impair functioning? And then finally, we try to answer these questions considering age, gender, culture, situation, and historical era. What are normal beliefs for a young child or a small child, such as having imaginary friends? We would not consider that normal behavior for an adult. The risk-taking behavior or the egocentrism that comes with adolescence, we would not consider that normal behavior for an adult. We see gender differences when it comes to mental health issues. We know more women report struggling with depression. Are they more susceptible to it, or are they more likely to report? We have to ask these difficult sorts of questions. So explaining psychological disorders. What causes abnormality? What causes abnormal behavior or mental health issues? When we look at explanatory models historically, we've had a tendency to explain abnormal behavior based on the supernatural or based on demonology. In other words, a person is behaving abnormally because it is the work of the devil or other supernatural forces. Centuries ago, explanations of abnormal behavior usually focused on gods or demons. A really great example of this is the Salem witch trials. In some cultures, supernatural explanations are still invoked. What I want you to understand is that the explanatory model that we use can really influence society's attitudes and responses to that person and to that mental health issue. In our culture, the media has a profound impact in the ways that mental health issues are displayed and the attitudes that society has towards individuals that are struggling with mental health issues. And this is why certain organizations such as NAMI feel very, very strongly that early detection is so important, getting an early diagnosis, and being open and discussing those issues gives it a sense of normalizing and decreases the likelihood of bias. Other explanatory models that psychologists would use would be focusing in on biological factors. We would call this a medical or neurobiological model. It's a view that the cause of mental illness stems from abnormalities in the brain or endocrine system. So if you think back to our lecture on biology, what we're looking at here are neurons. We're looking at neurotransmitters. How are those neurons communicating with one another? Are they functioning normally? Is there normal levels of neurotransmitter? Is there too much? Is there not enough? Or the endocrine system. The focus here is on hormones. Is an imbalance of hormones, too much or too little, a contributing factor to that person's mental health state? Psychological processes, or taking a psychological model. As we move through this lecture, we're going to be talking about different psychological models that'll help us to think about or frame up mental health issues in different ways. We've already talked about many of these models in past lectures. We look at sociocultural context. Again, we look at the role of gender, we look at the role of age, we look at the role of culture, and the impact or influence that might have on mental health. We know that there are some mental health issues that we call culture general. What that means is that mental health issue appears nearly everywhere in the world. A great example of this would be schizophrenia. We find that about 2% of the population struggles with schizophrenia, and it doesn't matter if you are from the United States, if you're from South Africa, if you're from India. It's a very steady statistical amount. We also know that there are culture-specific disorders. In other words, these are disorders that only seem to appear in a particular culture. A great example of this is Koro. We only seem to see this disorder in certain Southeastern Asian countries. This is the belief, a man would have this belief that his penis is going to shrivel up or shrink up and basically be absorbed back into the body and may lead to death. Often when we go to explain mental health issues, we take a biopsychosocial approach. In other words, we consider any biological factors that might be contributing. We look at any psychological model that might help us or contribute to the ways that we explain this mental health issue, and we take the social factors into consideration. I want to take a minute here to talk a little bit about a diathesis stress model. This is a very integrative explanation. Many psychologists use a diathesis stress model to help explain how a person develops a mental health issue. When I use that term diathesis stress model, what I'm talking about is a way of understanding the development of a specific disorder. A predisposition to a given disorder, that's called a diathesis, and specific factors or stressors that combine to trigger the onset of the disorder. So the diathesis looks at the genetic or biological component. Is the person genetically predisposed? Are they set up to develop a mental health issue? And the stressors, that looks at the ways the environment can trigger the mental health issue. In other words, a person could be genetically set up to suffer from depression, but it usually takes some environmental event, loss of a job, divorce, death of a loved one, death of a child, death of a parent, to trigger that depression. A really great example of this is one of the things that we know is a lot of mental health issues emerge in late adolescence, early adulthood. And what we believe is happening is that certain individuals might be genetically predisposed. They have a diathesis to a certain mental health issue. And what happens during late adolescence, early adulthood is now that person is facing the stressors of adulthood, having to go away from home, having to live independently, having to learn how to manage their time, having to learn how to manage their relationships, how to manage classes, how to manage a job, how to manage money, stay on a budget. And all these things combine and can pile up and push that person toward developing a mental health issue if they have a predisposition. So in this figure, we see diathesis, stress, and then ultimately disorder. As I mentioned, the diathesis stress model's explanation suggests that psychological disorder can result from many combinations of predisposition and stress. So point D here on the image, it shows the disorder stemming from a strong predisposition and relatively little stress, very little stress. At point C, we have a weak predisposition but lots of stress. And points A and B represents blends of diathesis and stress that are not necessarily potent enough to trigger disorder. So what are some psychological models that we use to help us to think through or explain psychopathology? We've already taken some time to talk about a neurobiological or medical approach. So in other words, is there an endocrine dysfunction or an endocrine imbalance? Is there a neurotransmitter imbalance that might have caused or be connected to a psychopathology? A psychodynamic approach really looks at this idea of intrapsychic conflict. Remember, when I say that term psychodynamic or psychoanalytic, I'm talking about Freud here. So in other words, are these psychological difficulties caused by conflict between the id, ego, and the superego? Is the ego strong enough to manage the conflict between the id and the superego? A cognitive approach focuses in on how a person thinks. Is the psychopathology or is the mental health issue the result of distorted thinking? A humanist approach looks at a mismatch between the real and the ideal self. Remember, we've talked about humanism with the work of Rogers and Maslow. The belief here is that psychological difficulties are caused by this incongruence between who the person is, the real self, and who that person wants to be, the ideal self. And finally, culture. Looking at the role that gender might play, the role that age or cultural distinctions might have on psychopathology. All right, we're going to move on now. We're going to talk a little bit about diagnosis and psychological disorders and how psychological disorders are identified and diagnosed. This is primarily done through the DSM, through the use of the DSM. The DSM is the Diagnostic and Statistical Manual. It is the manual that is used by clinicians, primarily psychologists and psychiatrists. And they use the DSM to help them to diagnose and treat their patients. Currently, we are on DSM-5. We're on the fifth version of this, and this has come out a couple years ago. The DSM-5 has moved more toward a categorical system of identification. It used to be that the DSM used axes. So when a client would come in and they would do a clinical intake, that clinician then would write what they found on 5 different axes. But that's not the case now. Now it's a more categorical system. And the clinician will write out on line 1 any clinical disorders or any relevant medical conditions that they are diagnosing within the client. On line 2, the clinician will list out any social or environmental problems that they feel are impacting that client. And then some clinicians are still using GAF, or a Global Assessment of Functioning. What this is, it is a number that is generated to help the clinician be able to communicate the level of functioning that the client is experiencing. So it's a scale that goes from 0 to 100, 100 being highest level of functioning. They are functioning very highly professionally. They're functioning highly or very well in their personal relationships. They're functioning well in terms of their education. And 0 means little to no functioning. While the DSM is an incredibly helpful manual, it sets parameters for clinicians in helping them in the process of identification. It is not without its criticisms, and there's quite a few criticisms of the DSM. The first primary criticism is that there isn't any discrete boundary separating normality from abnormality. So this is something that we've already discussed, that trying to tease apart what it really means to be abnormal can be incredibly challenging, and there's a lot of variables that can impact that. So it really relies on the judgment of the practitioner to be able to discern whether the feelings or cognitions or behaviors of the client are abnormal. The other serious issue that we've had with the DSM, and the current version of the DSM has tried to address this, is this idea of inter-rater reliability. So what that means is that if psychologists or psychiatrists or clinicians generally are given, say, a case study to read of a particular client, or a client goes in and they do a clinical intake, what we find is that that client is not consistently diagnosed, that we see divergence in the ways that a practitioner might come to view what mental health issue that client is struggling with. And so that really points to certain problems when it comes to diagnosis. In other words, it's very difficult to categorize, We know that symptoms are not unique to specific disorders. In other words, we see a lot of overlap with symptoms. Lack of sleep, for example, that can cut across both depression and also anxiety disorders. In addition to that, we see a lot of comorbidity. So we see a lot of mental health issues happening at the same time. For example, we see a lot of depression going on with a lot of substance abuse disorders. These diagnostic criteria are often open to interpretation. Is what the client telling you fit in a particular diagnostic criteria? That's often relies on the judgment of the practitioner. And a lot of clinicians are very critical of this idea of labeling. They see labeling people as being very dehumanizing and in many ways destabilizing. So this is a big debate right now in psychology, where you have some psychologists, and really I would say even most psychologists have moved toward this idea of early diagnosis, of early intervention, and that diagnosis is really the first step on getting onto that road of help and recovery. Then there's another group of psychologists who just argue, this is a dehumanizing practice. And especially if a person is labeled too early, if we're labeling children, that it becomes, the person becomes that label, that it becomes almost a self-fulfilling prophecy. They become their mental health issue. So let's try to think critically about this. Is psychological diagnosis biased? When you head into a clinician's office, can you count on them being able to diagnose you correctly? So what are you being asked to believe or to accept? Is there a bias in diagnosing African Americans? Well, there seems to be some evidence to support this claim. We see that more African Americans are diagnosed as schizophrenics. We see that African Americans are overrepresented in public mental health hospitals, and they're underrepresented in private hospitals and outpatient clinics. We see that African Americans are more frequently discharged without a definitive diagnosis. And we also see ethnic minorities, and this also goes for women, as being underrepresented in research on psychopathology. Now, does it mean that the reason why we're seeing more African Americans as being diagnosed with schizophrenia is that representative of misdiagnosis or overdiagnosis on the part of the practitioner? Poverty may play a role here. It may explain why African Americans seek help at less expensive public hospitals. And poverty may also create more stressors. Remember that diathesis stress model. It may create more stressors that lead to mental health issues. So it's very challenging. And what we do is we look for evidence that's going to help us to evaluate it. We conduct experiments. We look for evidence of some diagnostic bias in the research being done. And the biases found in studies examine the factors that influence diagnostic judgments. In other words, what we do is we then work harder to make clinicians aware of their potential biases and work on helping them to make more accurate diagnoses.